the saying is kiss your microphone. Not really. Okay, so call into order. Melinda, if you could do a roll call.
Sure. Dr. John Adams,
Present.
Dr. Martha Buchanan,
Present.
Dr. Diana Drake, Dr. Jack Gocher, Dr. Maria Hurt,
Present.
Mayor Glenn Jacobs, Miss Annie Roma, here, Dr. James Shamia,
Here.
Dr. Marcy Souza,
Here.
Miss Lisa Wagner,
Present.
Thanks. We do have a quorum, and let's just start with introductions. We have a new member to our board. I don't know if Dr. Buchanan, did you want to?
I'm happy to introduce Dr. Adams. So as we all are aware, Dr. O'Brien resigned his position on the board, and Dr. Adams was the Academy of Medicine nominee and was confirmed by County Commission in their last month's meeting, and this is his first meeting. Dr. Adams is a longtime physician and resident of Knox County. He is board certified in infectious diseases. He obtained his education, did a fellowship in Chapel Hill in infectious diseases, did his residency in internal medicine at the University of University of California in San Diego, and went to medical school at the University of North Carolina, Chapel Hill. He comes to us from the Covenant Health System and has been, again, serving our community as an infectious disease specialist for many years. I've known Dr. Adams since I've been practicing here. So welcome, Dr. Adams. If you'd like to say anything, the floor is yours.
Thank you very much, Martha. It's a pleasure to have been, and an honor to have been invited to serve on this panel. And I'm delighted to be here, delighted to be able to add my voice and my expertise to the health and welfare of East Tennessee in our Knox area.
Thanks, Dr. Adams. I welcome you here despite the fact that I went to North Carolina State University and is your rival for my veterinary education.
I will forgive you. But since Chapel Hill doesn't have a school of veterinary medicine,
true.
you really didn't have any choice.
Okay. Thanks. Have you met everyone on the board, or would you like us to just go through quick introductions?
Some brief introductions would help. I've met a few
Awesome.
people.
Great. Dr. Hurt, you want to start? Do you want to start with introductions, Dr. Hurt? Just a quick intro for Dr. Adams.
Maria Hurt, Clinical Assistant Professor of Nursing at UT.
And our Board of Nursing representative.
Yes, thank you.
James Shamia, we've met on variety of occasions. Yeah.
Marcy Souza, veterinarian with the College of Veterinary Medicine.
Martha Buchanan with the Health Department.
Melinda Goodman with the Health Department.
I'm Ani Roma. I'm the citizen representative on the board, advisory board.
I'm Lisa Wagner. I'm with Knox County Schools, and I used to work with Dr. Adams many years ago in ICU at St. Mary's on the Hills.
All right, thank you, everyone. And the agenda is in front of you, and I'll entertain a motion to set the agenda.
Motion to set the agenda as written.
Second.
All those in favor?
Aye.
Aye.
Any opposed? All right, the agenda is set. You had distributed the minutes from the last two meetings on June 16th as well as July 28th. They were distributed, I guess, earlier this week. I will entertain a motion to approve them both.
Move that we approve both as written.
Second.
All those in,
Yeah.
Actually,
Any discussion?
point of order, since you were not present at the meetings, I don't know that you can
you're
motion
probably
to
right.
Dr. Adams.
Good point.
Motion to approve the minutes is written.
Second.
All those in favor?
Aye.
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 Any abstention? All right, minutes are approved from our last two meetings. Next up is the Knox County Health Department update from Dr. Buchanan.
Thank you. Okay, good. You can see before you, you have the handout of the slides that are also being projected on the monitor. So first, I just want to talk briefly about what we're continuing to do at the health department as part of our COVID-19 response. We are currently vaccinating at the health department clinics 5 days a week. Additionally, we are in the community providing COVID vaccines at businesses, nonprofits, churches, and other organizations in an effort to make the vaccine more accessible and meet folks where they are. I think we have one coming up at a couple local business and some at schools. So we really are trying to get vaccine out there so that we can maximize the number of people who are vaccinated in our community. We are contact tracing now 7 days a week. And in order to free up staff for other public health activities like vaccination, including flu vaccine, which is also on the horizon, we have outsourced testing to a local company. They started Monday, so we're just getting started with them. They run the clinic, they collect the specimens, they have the lab, they process the specimens and get the results to the patients. So this really frees up a lot of our staff. They currently are testing only the uninsured, but are considering expanding that to insured patients as they get the workflow down in a new space. And so our public information line is also operating 5 days a week, and they can be reached at 865-215-5555, and they can answer questions about everything from quarantine, isolation, where you can get a vaccine, where you can get tested, and other information such as that. And now we'll move on to the data. The first graph shows COVID cases from June through today. Since mid-July, we've seen a steep increase in new cases. Most days we've been reporting out several hundred new cases a day. The second graph shows our 7 to 14 day trend line of confirmed cases of COVID per 100,000 population. So this is our rate. And if you look at this, the encouraging part of this graph is that we might be trending down a little bit, or at least flattening out somewhat in our new cases per 100,000. So that's encouraging. We hope that trend continues. The third graph shows COVID cases over time broken down by age. You can see that the age group with this, nope, that one. Yeah, I was like, that's the wrong one. Thank you. You can see the age with the steepest rate of increase is the 5 to 17-year-old group. In other words, school-age children. Some days we've seen more than 250 cases a day in this age group. The 31 to 40-year-old age group is the second highest rate of increase. So the big takeaway here is that we are seeing a younger population infected with COVID than we saw last year. And you can see from when you look at the vaccination data, you can kind of see why that's happening. But the spikes, in particular, the orange spikes, or that's what color they look like to me, those are the 5 to 17-year-olds, and that's a really impressive slope, something we never saw last year. So it's been quite impressive that those unvaccinated, a lot of those kids are unvaccinated because they can't get vaccinated. We're seeing cases in there. And the fourth graph shows our hospitalized patients, those in the ICU and those on the ventilator. Dr. Shamiya will have a deeper dive into this shortly, so I won't spend much time here. But I do want to, again, draw your attention to the steep rise of hospitalizations that we've had in the recent past. Hospitalizations have increased at a faster rate during this time period than they ever have at any point in the pandemic. And I know you folks who are working in the hospitals know that without a doubt. So our fifth graph shows the deaths related to COVID over the past several months. When we last met, I expressed worry that these numbers would increase as deaths are often a lagging indicator. And unfortunately, that has turned out to be the case. You can see that deaths have greatly increased from what we were seeing back in June, which is the last time we met. And then the next graph will illustrate this even more. In this chart, you see deaths in August and September of this year. Sorry, let me start over. Okay. You can see from this chart that we have had more deaths in August and September of this year than we did last during the same months. The devastating reality of this is that this time around, we have a safe and effective vaccine that is widely available and could prevent some of these deaths. Unfortunately, we know many of these individuals were not vaccinated. We are also seeing younger populations suffering from severe disease and dying from COVID than we saw last year. So that is, sorry, 1 second. Yeah. So that's deaths by month. Those deaths are broken down by month. It took me a minute when I looked at this the first time to get that. So those are broken down by month.
And Dr. Buchanan,
yes.
that's Knox County residents?
That's Knox County residents, yes. And then on the next graph, you can see vaccination rates or table among Knox County residents. The really encouraging piece of information here is that more than 80% of those 65 and older are vaccinated against COVID-19. And that is a phenomenal percentage, one we wish could see across the board, but we don't. Unfortunately, as we look at our younger age groups, the number drops down quite a bit to about 50%, which is better than some places, but we'd like to see that number much higher. The number one message I think we need to get out to our community continues to be get vaccinated. I would add to that also continue to wear your mask as we have such low numbers of vaccinated people. The best protection available to keep you from going to the hospital and even dying from this virus is vaccine. Additionally, we need to be practicing layered mitigation strategies, which means wearing a mask when in public indoor spaces, physically distancing, staying home when you're sick, or you've been told to isolate or quarantine, and frequently washing your hands. These actions all coupled together are the best things we can do to keep ourselves and our loved ones safe. Everybody wants this pandemic to be over, and this is the best and fastest way we can accomplish that. So I'm happy to entertain any questions.
Any questions for Dr. Buchanan? All right, seeing none, Dr. Shmia?
Thank you. So one thing I have to remind myself of, it's been a decent little bit of time since we've all been together. And so we've been on the hospital side totally kind of immersed in this and trying to provide updates weekly. And so I'll try to not give you just the what's happening right now, but kind of the context of what's happened over the last several weeks. So the first slide really just talks about that over the last several weeks, there's been a gradual shift in focus. We initially were just talking about cases rising, then hospitalizations rising, the same things we talked about in December and January. But then it became a conversation to some extent about resources. Specifically, we were seeing more patients in the intensive care unit this time around than we had before, without question. And of those, significantly, it's a younger group, and it's significantly more on the ventilator than before. And so a lot of the conversation regionally, particularly that escalated in leading up to the last few weeks, was about staffed ICU beds. And then also to some extent about equipment. And so I think if there was anything I would say that was a distinct difference this time, I'm not saying those things were not issues last time, but it definitely was more in the forefront this time. So then moving on to the data, the next two slides, I just want to compare and contrast kind of what we experienced in the winter surge and then what we've just kind of been, or we're currently going through. And so if you look in December and January, it seemed really bad at the time, but the rate of rise was not particularly high. It really was a gradual rise of November into December and then into January. And so I've just shown you, circled a 30-day period. The other thing you notice here is if you compare the purple line to the red and blue, and these are similar things that this came off the Knox County Health Department website, but what you see is that there were not that many in the ICU compared to, if we look at the next slide, The first point is just how steep and rapid this rise has been. And so making adjustments and anticipating the future has been particularly challenging. The second point there is just that there is, as I've already stated, there were significantly more, a higher percentage in the intensive care unit and more of those on the ventilator. And so there was a day, I think it was September the 13th, where if you took all of our ICU beds between the COVID patients who were on the ventilator, which was about 35, and all of our other patients who were on a ventilator, 70% of all of our ICU patients were on a ventilator. That's very significant because those people are going to be, if they survive, be in the hospital longer. They're going to take more resources. They have a high level of expertise that's required. Now, the other thing I will say, and this slide, I prepared it this morning, so you'll see it cut off at the 18th, but I believe, Dr. Buchanan, what you projected was a few days more recent because it got posted this afternoon. But what you see is kind of a leveling off there at the end. And so, you know, there is at least some suggestion for whatever reason or whatever combination of reasons that the hospital census piece is starting to level off. And so we'll have to watch that very closely. But the other thing I would say is, I mean, honestly, the purple may have even dropped a bit, but we're not seeing any dropping in the ICU portion of that, at least not yet. And so the next slide, I've just contrasted some numbers between the winter peak, September the 10th, which was not that long ago, and then September the 17th. And again, what's on the website now is a little more recent, but you see that the total has dropped. First of all, look at how much higher we got on September 10th compared to the winter peak. 757 patients versus 671. But you see there has been a drop, and I believe today's data shows a drop. I think it's gone below 700 at this point. But then if you look at the ICU piece and you look at the ventilator piece, those have not started to drop and respond. And so it's something we've got to keep our eye on. So then just, again, talking a little more about, on the next slide, about the resource piece. I mean, what does it mean when you have more patients in the ICU who are sicker and you're trying to manage in the region staffed ICU beds? One thing is that a lot of the narrative about this ends up being about ventilators, pure and simple. And obviously that's a very important narrative, but we've felt comfortable with the number of ventilators that we've had in the region, at least up to now. But you also have to realize that they're not all the same. And so that some of these patients are some of the sickest patients need the most sophisticated ventilators, and not all the ventilators in circulation are at that level of sophistication. The second thing that doesn't get talked about as much is dialysis. And so when you have that many patients who are critically ill, then more patients, when you're critically ill, you're more likely for your kidneys to have problems. And sometimes you have to support that with dialysis. And that's a resource that doesn't get talked about. So that's a conversation we were having is, you know, we have to make sure that we have the appropriate amount of dialysis in the region for all the patients that are sick. The next consequence of this is that what happens when you are having more patients in the intensive care unit is naturally sicker patients will be in the hospital, not in the intensive care unit. And so effectively your entire building is sicker than it was before. And there's kind of a domino effect of that. And as we've mentioned before, a lot of this has been about staffing for the healthcare system, but creating, because of the level of expertise required, creating a staffed ICU bed is harder to do than to create a staffed extra regular bed. So then moving on, this is the last 60 days for us. And I don't know that the numbers are, and I believe this was as of yesterday, just to be clear, but you see our mortalities are deaths. And so we had this sense that maybe the mortalities would be overall less this time because of a younger group of patients. But we've also had a lot more people just going through, you know, just admitted discharge. And so basically we've had more than a death a day on average, which is still a very formidable amount of mortality. The next slide, kind of on the home stretch here with the last few. And so this is just, I think, to help drive home the vaccination message is that, and we've, I think the hospital systems have this time around been very much showing different types of data so that the community is aware. We show our daily numbers, but what this does is these are all the patients that were discharged from our hospital since the 7th of August. And on the left, you see just kind of the different percentages. And I actually think this is sometimes confusing to the community, but here you see the red is 78.5% are not vaccinated. To us, that means they didn't start. They haven't had a single dose of vaccine. Then of the hospitalized population, 4.3% were in process. So they got a dose, but they didn't finish. It was a 2-dose series. And then 17.2% of our data were fully vaccinated. And so, overwhelmingly a population of folks who had not gotten a dose, but still those other groups were part of that. I think the lower right is a story you don't hear as much, and that is these are our mortalities, our deaths since that same day. And you see the percentages as far as the vaccination rates is very similar. But we also showed the age, the average age for each of those groups. So you see that for those who passed away from COVID-19, if they were fully vaccinated, and again, it's a small group, average age was 79. For those who had not had a single dose, the average age was 66. And so to have that average, we've seen a lot that were significantly younger than that. And so still so important to drive home the vaccine message. And then finally, because this is definitely a topic right now, I wanted to talk about, from a hospital perspective, the monoclonal antibody a little bit. And so this is just from our facility. But these are and I believe this is since yesterday. These are the doses of monoclonal antibody, outpatient monoclonal antibody that we've administered. And so another stark contrast to the winter surge. You see how many doses we gave in December and January, and then how many were given in August and September, with the month not even over yet. And the idea of the monoclonal antibody is that if you treat 100 of the appropriate patients, you may keep maybe 3 or 4 out of the hospital, I believe. And so that is an important, it's an important therapy. And at this point, and we're not sure exactly what the future holds, but we are getting a sense that the supply may be less than it's been. And so we are following the guidance we've been given to make sure that those patients who are at highest risk and those who will benefit from it the most are the ones that receive it first anyway, so that we're, in the event that we have a shortage of supply. And so, that ends the slide part. I guess the one thing I would add is that, just from our perspective, it has been a dicey last several weeks, particularly the last few. And if that is starting to level off, we could not be more relieved. I'm not ready to definitively say that yet. But what I also want to say is that if that's the case, even more than ever, it's time to be careful and do those actions, because it's always a shame if what I just showed was a population. It's not an individual. And so that individual is still, if they get COVID-19 and they're at risk and they end up in the hospital or end up in the intensive care, to that person or that person's family, these graphs don't matter. And so I think that needs to be an important part of the message, because we're very much hoping that these numbers are going to start to turn the corner. I believe that concludes my report.
Quick question. On your vaccination status and hospitalized patients, the first graph, is that all patients or just COVID positive patients?
Oh, that is only COVID positive
Okay,
patients.
thank you.
Yeah. James, have you seen any impact yet from the new federal allocation for antibody and that sort of stuff? I didn't know if we've seen any reduction in.
We have, so the way that was working was a very, very rapid delivery. You'd order, you get, you order, you get. And because you're generally calling today for tomorrow's infusions, scheduling people today for tomorrow, that's the way that works. That was working pretty well. I can say that we got what we expected this past week, but we know that there are others who got less than they expected. And so we're still not really sure what that's going to mean from a supply standpoint.
Okay, thank you.
Yeah, so what's happened with that allocation is the federal government is allocating monoclonal antibody based on disease burden to each state, and then the states are allocating monoclonal antibody to providers based on previous use and other factors. There are other factors they consider in that. So that is kind of what's happened. So the federal government and the state have changed how they allocate.
Dr. Shamia, what is the time between someone comes in and administering the monoclonal antibodies? What is
Can you repeat that so that?
Yeah, so the question was, what is the time frame between when somebody comes in and
has to
giving,
have it? I mean,
between when they get COVID-19?
yes.
So the way that this is another one of these things that's under emergency use authorization, and the way that's written is that to be able to be a candidate for it, you need to be within 10 days of symptom onset. And if you're sick enough to be hospitalized, you're not a candidate for it. The point of it is to try to prevent people who are at high risk of needing the hospital, prevent them from getting sick enough to end up being hospitalized. And honestly, there are some, we know already there are some patients that are inherently at higher risk to end up in the hospital than others. And so if the supply does become constrained, the guidance that has been given tries to direct the doses to those who are at the highest risk. Dr. Buchanan, is that a fair way to
That is
summarize
correct.
If I might make an addendum comment to one of James' excellent slides, the domino effect that he mentioned extends well beyond this immediate area. All of our major hospitals serve as referral centers for the sicker patients throughout East Tennessee. And during the worst of this, we have found that there was actually, I hate to say it, a waiting list to get into the ICU. It's been so overwhelming that they've been trying to figure out ways to manage patients at outlying hospitals that otherwise would have been readily brought into Knoxville. We've had patients who presented to our facilities having to stay for extended periods in ICU status effectively in the emergency room. My applause and gratitude to the critical care staffs, my physician colleagues and the nurses, RTs, all the ancillary personnel who have been really burning the candle at both ends to try to take care of the volumes. But I think we can't understate the domino effect of our local facilities backing up is impacting well beyond this county. And hopefully what we're seeing with the flattening is real and it's going to sustain, and it's going to be a drop so that we can get back to being able to handle other patients. But wanted to underscore that domino effect it's got some big dominoes that go a long ways out.
And I'd like to then add a point that the community still has a Zoom call 3 times a week at 1 p.m. And that's been very useful this time. Actually, I think probably more helpful this time around than the last time around in terms of the determining what everybody's situation is in the region. That's not just our local community, but in the region. We still do have concerns that, just because the hospitals are full, we want the people who truly need emergent care to seek it. And that goes for all kinds of other diagnoses. And that's been one of my main themes over the last several weeks is when the healthcare delivery system experiences a stress, that stress ends up impacting all patients. And if the ICUs are experiencing a stress, that stress impacts all patients. It is not just about patients with COVID-19. But the message that we don't want to send is that people should avoid, for non-COVID illness or for COVID illness, that people should avoid seeking care when they need it because of concern that the healthcare system, can't take care of them. We want those people to seek care, but we've also been very clear that if you don't need an emergency department for whatever is, urgent cares are there, walk-in clinics are there, primary care doctors are there. There's all kinds of other ways to seek care.
Any other questions or comments? Lisa?
Questions today?
Make sure you speak up, please.
Okay. What about Regeneron? Am I pronouncing that correctly?
Yes, you are.
So is it the same? Do you use the same guidelines for the monoclonal antibodies? For
So those are
Regeneron?
one and the same, actually.
Oh, really?
There's
Okay.
two different monoclonal antibody products that are currently under an EUA. One of them is the Regeneron.
Any other questions, comments? Thank you, Dr. Shamia. That moves us on to other business. And I guess I would like to just see if Lisa has anything that she wants to share from the schools.
I think it's been a couple of weeks ago that they have the dashboard at the individual schools. And so we started that.
Okay.
Yes.
And I guess I saw on the county's website today that the student, I guess the 5 through 17 numbers are also reported. And I wasn't sure if we were going to have a UT representative here from the health center, but so I looked up the numbers just quickly before coming. But so just the numbers of cases at UT has actually been decreasing over the last week or so. It looks like as of yesterday, there was 16 active employee cases, 71 active student cases, and that there was 6 new cases reported yesterday. So the curve's kind of been dropping. Hopefully that's true and not just avoiding testing, but that those numbers are available on utk.edu's website. Any other business?
So I had a question. I think this is probably more for Dr. Buchanan, and I don't know if it's an answerable question. But obviously, Dr. Buchanan, you're in the process of making some transitions, and I think we've said before, but we couldn't be more grateful to you for your service. I guess I'm not sure the date of our next regularly scheduled meeting, and I don't know what your status will be, but quite frankly, I'm still not exactly clear exactly whom this advisory board of health is advising. And maybe if I know who it is now, I'm not sure I know exactly who will that be going forward, even by title. And so is that something that you can help us understand? Because if we're going to participate, I just want to know what we're doing.
Yeah, sure. So thank you. So if you look at the ordinance as written, the Knox County ordinance, the advisory board of health is advising the health department. It doesn't say the health officer, it says the health department specifically, and that's the wording that they used. And I don't know if anybody can pull it up real quickly. I don't think it mentions the mayor. I looked at it yesterday and now I'm drawing a blank if it mentions the mayor. So you're advising the health department, which would be the director and the health officer. So just to kind of update you on my status while Catherine's looking that up. I will be the director until the end of this month, or actually next Friday specifically. And then I will stay on as health officer until the end of this calendar year. So our next meeting will be in December, as we're meeting quarterly. So I will be at the next meeting, and that will probably be my last meeting with this body. To let you know what the county is doing to replace the 2 positions, they have put out an RFP for an executive search firm. That executive search firm, that closes, I think, at the end of this month. That'll take a little bit of time to get that group in place. That executive search firm will then be searching for the director and the health officer. to fill those two positions. In the interim, Catherine Killen and Kevin Parton are, Catherine, who's our strategy officer, chief strategy officer, and Kevin's the chief administrative officer. They have divided up the director roles, and most of those roles are administrative roles. And so they will be doing those roles over the next, until the end of this calendar year, or until there's a director in place. So for most of you, and what you deal with the health department, you'll still deal with me until the end of the year. I will remain as incident commander for the COVID response, for continuity from our staff and for the trajectory of the response. The health officer and the health director both are ex officio members of this body, so I will continue to attend the meetings until the end of the year. So for that part, and I believe Catherine will be representing the director on this body, and she's been engaged and involved in the meetings with you all throughout. So even after I leave, you'll have that continuity of Catherine for a period of time until there's a director named.
Okay.
So does that clarify?
Yeah, thank you.
Sure.
Other questions, concerns, business that needs to be brought up? I will entertain a motion to adjourn then.
Motion to adjourn.
Second.
Moved.
Second.
So moved. We'll see you. Next meeting is December, Melinda? December 22nd in this room?
December 22nd,
In this room?
in the main.
Okay, in this room, December 22nd. Same place. Thanks, everyone. Go enjoy the nice weather.